Okay, so my name is Dr. Craig Kasper. I am the managing director and founder of NYHD, which is the Institute for Hearing and Balance based here in New York City. Very happy that you are joining us today for this very first episode of NYHD Life Live. We are actually putting together some installments of interviews with professionals, people of interest who are in our world that we believe can help shed some light on some really interesting topics, but also provide you with information that ultimately will let you lead a healthier, happier, more optimized life. Now, as I said, this is the first episode of this particular show. And for that, I'm very, very excited to bring to the screen in just a moment a good buddy of mine and colleague, Dr. Joe Sakumura. He is based in Tampa, Florida, and he works with an organization called the American Institute of Balance, which all of us here at NYHD work very, very closely with as well. I just want to read a little bit of Joe's background here for a second. Joe received his Doctor of Audiology degree from the University of Kansas. He also obtained his undergraduate degree from there as well. He completed his clinical residency in a very unique place, the American Institute of Balance, where he focused wholeheartedly on balance disorders and vestibular assessments and how to help people who have issues with balance. He is, as I said, the director of clinical innovation there. His primary interests are in the diagnosis and the rehabilitation of balance disorders from children all the way up through adults. So with that, I'm going to bring Joe into the mix here, and there he is. Hey, Joe, how you doing?
Hey, Craig, thanks for having me. Appreciate it.
It's my pleasure. I really appreciate you taking the time. I know that you have a busy clinical day just like I do. So it's really good to see you again.
Yeah, you as well. Yeah, thanks for having me.
So I gave the audience a little bit of an understanding of your background, but as I said, vestibular disorders and the interest in vestibular disorders, especially for someone in audiology, is not exactly the norm. Most audiologists are primarily focused on the hearing system. What kind of set you on that path down the world of vestibular?
Yeah, so one of the things that people don't, think of necessarily, their first thought to jump to when you think audiology is not necessarily balance or the mechanisms that create equilibrium and balance within people. So one of the interesting things that I had very early on within my career is family members that are having things like falls and dizziness. And of course, we know that the number one complaint of individuals over the age of 65 to their physician is actually dizziness. We get a lot of hype and a lot of things, a lot of discussion revolving around hearing loss, but the audiologist's role within equilibrium and within balance is actually really, really critical. So, early on in my career, I had a lot of family members that were suffering these really nasty falls and dizziness and things, and their physicians oftentimes telling them, you're getting old, this is something that you've got to live with. And of course, in our field of study, and one of our mottos at the Institute here is you don't have to learn to live with it. The science and the research and things have come so far. And I know one of the topics we're going to be covering today specifically is BPPV. Dizziness and these kind of things a lot of times are very, very treatable. So it's a really, really rewarding kind of a subspecialty within audiology. We obviously know how critically important the hearing mechanism is to quality of life, but that same thing, those same concepts can also be applied to balance and the vestibular mechanism within the inner ear.
Sure. And what a lot of people may or may not really understand is that the portion of the vestibular system, the inner ear, consists of the hearing and the balance portion. So there's a lot of overlap in terms of if there's a problem with one, oftentimes there's a problem with the other, symptoms, signs, et cetera, that can kind of lead us down a certain path to trying to figure out what might be causing one problem or the other.
Absolutely. Yeah. And, the neurodiagnostics that we believe in, and of course, you guys at New York Hearing Doctors, is not only comprehensive diagnostics within the hearing organ to assess and treat any undiagnosed hearing loss, but also balance dysfunction that may be interplaying and all these different kind of things that go along with that.
100%. So why don't we jump into it a little bit? BPPV, benign paroxysmal positional vertigo, is a very common term that's kind of floated around. It seems like every single patient that goes to the emergency room or their primary care doctor with some form of dizziness is ultimately diagnosed with BPPV. Sure. It is actually pretty common, but maybe we could start in very, very basic terms, understanding that some people out there might not even know what BPPV is. Maybe you could describe what exactly BPPV is.
Yeah, absolutely. So patients that are suffering with any type of dizziness or balance problems, which can be referred to as vertigo or lightheadedness or any of these kind of things, it should first be stated that comprehensive diagnostics and seeing someone in the profession, maybe within audiology or ear, nose, and throat, have to be consulted first, because it can be very difficult to differentiate between some of, what exactly is the cause of dizziness. So we know that there are a large majority of, huge number of patients out there that are suffering from dizziness. The most common cause of dizziness actually comes from the inner ear. And it's this BPPV condition that you're talking about, also referred to kind of the street name called crystals within the ear. And what happens with this is, you have basically two portions of the inner ear. You've got a gravity sensor. So one part of your inner ear is telling your legs and feet about where they are with respect to Mother Earth. And then you've got a different part of the ear that's responsible for telling your head kind of where it is in space.
It's kind of like a gyroscope, correct?
Exactly, a gyroscope, just like on an airplane. Mm-hmm. What happens with BPPV is you actually get some of the sensory structures that are supposed to be giving weight to the gravity organ. They get mixed up and get mixed into the gyroscope and cause this sensation of what's called vertigo. In other words, in the medical terminology, the hallucination that the room is spinning. Much different from lightheadedness, much different from wobbliness or dizziness or some of these kind of things. And that can be really the first kind of clue into the professional to if this is an inner ear problem or not, if the individual has actually experienced any type of room spinning sensation.
That's a very important distinction that you made right there, because a lot of patients will come to us and say, I have vertigo, which is a blanket term that we found for all types of dizziness, where what you're describing to us is vertigo is an actual sensation of spinning or movement.
Yeah.
Okay.
And that's another, just to reiterate, to double down on this, even some of the best intentioned healthcare professionals, physicians even, you'll see if they're not comfortable with treating these populations, like an audiologist or a physical therapist may be, you may see people diagnosed with vertigo. But it's important to understand that we've got to figure out what the root cause of that actual sensation of vertigo is. Oftentimes it's related to the inner ear. The most common of these issues is BPPV.
So let's talk about that. How common is it, and who is more likely to experience BPPV?
Yeah, so BPPV is extremely common, and some of the really large scale studies that have been done most recently in Germany, looking at 70 million elderly individuals, their estimates are as high as 6% of the population are walking around with undiagnosed, untreated BPPV, which, if you look at any epidemiological data, huge number. Yeah. And the way that we kind of extrapolate that to our individuals that we treat is 50% of the time, if we're dealing with an individual over the age of 70, they've had BPPV before. You've got a coin flip's chance. What makes it more common, we're now learning what some of the causes of these are, is any fluctuations in systemic problems with blood sugar. So things like diabetes and high blood sugar levels, blood pressure, so hypertension, hypotension. Even some studies are suggesting levels of hydration. You've also got to keep this in mind if you've got a patient with any neurologic history of things like stroke or heart attack. Any of these things can be a precursor to higher risk of BPPV.
Gotcha.
The last thing I'll discuss just briefly is we know that vitamin D deficiency is a huge problem within the population now. Some of the studies showing up to 70% of people in the US are actually deficient. Well, vitamin D plays a huge role in the ear with the management of these crystals and these structures. If you're found to be low in vitamin D, the likelihood that you're going to suffer from this also goes up significantly.
So let's kind of put a pin in that vitamin D comment for just a second.
Yeah.
So the majority of North America, if we're just talking about where we live, basically, so the majority of North America, 3/4 of it during the winter months is probably vitamin D deficient. Yeah. Because of a lack of sufficient exposure to sunlight, which ultimately helps us convert it and produce vitamin D. Does supplementation actually help reduce the incidence of BPPV?
So some of the studies, the findings are mixed right now. Okay. So what we found a relationship between low vitamin D and recurrent BPPV. What we're now kind of in the phases of doing, remember this stuff's all relatively new, 2013, 14, 15. What we're now in the process of doing is determining if correcting the vitamin D levels with things like supplementation, which you might be able to even get over the counter, actually corrects this higher risk factor of contracting BPPV, if you will.
Sure. So what you're recommending for patients, especially for people who have recurrent BPPV, are you recommending that they get their vitamin D levels tested just to see where they're at?
Absolutely. So if somebody ever comes in with recurrent BPPV, we know that it's, we'll talk about this, I'm sure, but very responsive to treatment with very low recurrence rates. So that's the good news with this, is that it's benign in nature, and the treatment for it is non-surgical, and it's not medication. But if somebody does come back with recurrent issues, even after being treated a couple of different times, we'll always recommend that they have a panel done looking specifically at vitamin D, because while many, especially females of a certain age, if there are bone density issues and these kind of things, that'll be on their standard blood work, it's kind of alarming at how many times patients aren't aware of where their actual levels are. So if a physician, go ahead.
I'm sorry, go ahead.
Yeah, if a physician does then find that the vitamin D levels are low, they can then intervene with, maybe they need a prescription dose, a loading dose, a maximum dose of vitamin D, or maybe they'll be okay with the patient going and getting the supplementation over the counter, depending on where the lab levels show they are.
Is there a certain trigger level that alarms you, the physician that you're working with, that says that there's vitamin D deficiency?
Yeah, it depends on the patient. It depends on the physician. Typically, what you'll find with most labs is these are measured in what's called nanograms per deciliter. Anytime that somebody's below the range of 30 to 40 nanograms per deciliter, it can be kind of a borderline, potentially a low patient. So depending on how the physician wants to go forward, it all just depends. But if they're in the 0 to 10, the 10 to 20 range, absolutely they can benefit from supplementation. But you have to be a little bit careful, both as a provider and as a patient. It's a fat-soluble vitamin, so it can be damaging for some of the organs, the liver, the kidneys, if you have too much vitamin D. So it's always important to have the primary care physician or some sort of a medical physician involved when you're managing this.
That's a great point. Associated with vitamin D deficiency, we have, as you mentioned, a little bit about bone density issues before, osteopenia, osteoporosis. Does that put people at a higher risk for BPPV?
Absolutely. Those studies are even stronger. That's sort of where all the vitamin D work started, was looking at risk as a risk factor for BPPV, these bone density, whether it's even, the more minor osteopenia versus the progression into osteoporosis. Absolutely. Anytime that a patient has a history of either of those, they could benefit from a workup from an audiologist to make sure that this isn't a concomitant problem.
That sounds great. You touched a little bit upon the fact that it is called benign for a reason, and that it's easily treatable. It's probably, in our world as audiologists and even our colleagues in physical therapy, it's one of those wonderful conditions that we actually do have the ability to treat and fix somebody. So maybe you can address the diagnosis of BPPV, how we do that, and then ultimately how that translates into how we're treating BPPV.
Yeah. Really good question. So, BPPV is one of those really rare medical conditions that causes a really, really high level of functional impairment. And I'll talk about that in just a second, but then also is extremely responsive and really, really quickly responsive to treatment. So we really, truthfully, even if you look at some of these papers that are written, it's known as a cure for this condition. So what BPPV stands for is benign, so non-life-threatening, paroxysmal, so kind of rapid onset symptoms, positional, so it's positionally provoked, and vertigo, or the sensation of room spinning. So what the patient will typically experience is different levels of vertical head pitch, so moving the head up, lying flat in bed, rolling over in bed, but positional changes bring on these short duration episodes of really, really intense symptoms. So the way that the audiologist goes about, or physical therapist goes about evaluating this, is they lie the patient down in some of these positions that are known to provoke vertigo. Then the treatment for this subsequently, after you've diagnosed the condition, is really, really quite simple and comfortable. People often get worried about, how are they going to treat the dizziness? Do they have to do this? Do they have to do that? It's really almost as simple as rolling over in bed. We have to maneuver the apparatus, the vestibular system, in such a way that we replace these little debris that are out of place back into their home where they're designed to be.
Gotcha. Which leads to another question, and we have a lot of patients who come in and they'll see videos online about self-treating symptoms. How do you feel about that?
Yeah, you have to be careful with those. Just like anything in healthcare, when you Google this, there'll be a million different opinions on what you ought to do for it. Really, the gold standard of treatment, Craig, is to meet with some type of healthcare professional that's specifically trained to put you through these maneuvers, because it's a double-edged sword talking about the simplicity of these maneuvers. But the audiologist, like myself or you or the physical therapist, is actually specifically trained with where the head needs to be and for how long, and the different positions that the patient has to be progressed through in order to effectively treat it. If done incorrectly, you can actually move these crystals in the wrong way and can end up making the patient even worse, again, leading to vomiting, nausea, sweating, even emergency hospitalization, and these different kind of things if you're not careful.
Gotcha. I appreciate you sharing that, because we do see a fair amount of patients who will, of course, we all go to YouTube and we're Dr. Google and we try to figure out how to address our symptoms as quickly as possible before we see a physician sometimes, especially when it comes to dizziness. Patients are really, really uncomfortable. They want to figure this out. And if someone says, try these maneuvers, sometimes it's helpful, but as you said, sometimes we've had patients come in where they've gone in the wrong direction.
And the other thing that we have to keep in mind here, of course, is that while this one condition that causes vertigo is benign and non-life-threatening, non-damage causing, there are a number of other conditions that are not so. So it's really important to see someone like you all at New York Hearing Doctors or some sort of a professional to rule out other causes of vertigo before you really proceed with these treatments like we're talking about.
That's a really, really important point. So what about the use of meclizine for BPPV? That's a common blanket drug that's given for dizziness. We have a lot of patients who say they've been diagnosed with BPPV and given something like meclizine. What are your thoughts on that?
Yeah. So, like I mentioned before, the average, physician that may be seeing these patients initially in an outpatient urgent care, an emergency room, or these kind of things, remember, they're not always fit to run full diagnostics of the ear to determine what the problem is. So you'll often see that they'll manage it with what's called meclizine, which is really no different from a Dramamine or a seasick pill. Meclizine is designed to dampen the central nervous system and, kind of like ibuprofen would for a headache, help give a little bit of relief from the symptoms that are associated with the root cause of this. Of course, the medicine meclizine does not fix, does not mitigate, does not change the problem that's happening in the ear. And, if you can treat this, sometimes within 1 or 2 visits, it's unnecessary to take meclizine beyond that.
Sure. Final question about BPPV, and I could probably talk to you about BPPV all day long because of the wealth of knowledge that you have there. Is there any way to prevent it outside of dealing with the vitamin D deficiencies potentially? There are other things that could potentially cause BPPV or contribute to its presence as well. We didn't talk much about head trauma or concussion, but those things clearly have actually, maybe we could talk a little bit about that, because that's becoming a more interesting and more important topic, especially with kids, head trauma, sports. Maybe we could talk a little bit about the connection with head trauma and BPPV.
Absolutely. That's a huge, important topic to cover. Concussion is kind of a buzzword right now that's got a lot of traction because of what we know about the sport world and children and the DO, even the Defense Department and all these kind of things. Concussion, while the majority of what we read on this is actually happening in the brain, microstructural damage to the brain, it can also have a profound effect on the inner ear apparatus, both from a hearing standpoint and a balance standpoint. These crystals that we're talking about, this debris that's displaced when we're talking about BPPV, can also be thrown out of place with things like a sport concussion or a fall off of a skateboard or a motor vehicle accident. So while this condition that we're talking about, BPPV, is much more common in the older individual, We treat a lot of kids here in Florida in our area that are coming in with these conditions, these balance problems, this dizziness after concussion. Concussion rehab is also kind of a big hot topic right now because of what we know about the changes in the brain and how really also physical therapy and some of these exercises are the gold standard treatment to treat concussion.
Yep.
So as far as the inner ear goes, we're now learning the studies that are coming out are really, really sophisticated and impressive, regarding what exactly is happening to the inner ear from a structural standpoint after a head injury. And we know that the changes can actually be pretty profound now, looking at different bone changes and anatomical changes and these kind of things.
Yeah, it's definitely getting the world of brain science and concussions in particular is getting very, very interesting.
Yeah.
So is there anything about BPPV that I didn't ask you that you think is really important for us to understand?
Yeah, the reality of it is the biggest thing when we use terms like benign, and we're starting to see people treat this on their own at home and using Google and YouTube and all these kind of things, we've got to keep in mind that it's a really, really profound, strong sensation that it's giving these patients. And not only does it give them these really intense bouts of spinning, but if you look at some of the data on quality of life, things like anxiety, depression, and specifically what we didn't talk about yet was fall risk. So we know that levels of anxiety go way up. We know people are withholding from different activities during their day because of this. But we also know that fall risk goes up threefold when you have undiagnosed, untreated BPPV. So when we go around and we're talking about physicians, about specifically the importance of thorough audiologic examination and treatment, falls are not only, they can be devastating for a person, but also from a medical economic standpoint, they're a huge, huge deal. We know that the easiest way to reduce fall risk in the elderly is to treat undiagnosed, untreated BPPV. And it makes it really, really critical that an audiologist gets involved to determine what the cause of these symptoms are and ultimately be a part of the treatment plan as well.
I'm really, really happy you brought up the concept of falls because, as you said, it's a huge burden from a financial perspective, but even more important on the individual, the family, one of the leading causes of death is falls. So we have to get ahead.
We know that the number, this talking with your patients, and we know this from the studies, that the number one goal of our elderly population is independence. They want to stay independent. And the quickest thing that's going to lead to dependence and being bedridden and kind of this vicious cycle of downward spiral is a fall. We know that the mortality rate of a hip fracture, for example, is about 36% of people don't make it through that. And if it's something that can be treated as easily as BPPV can, and it brings fall risk and some of these other associated issues down that much, we've got to really, really harp on education and letting people know that you don't just have to learn to live with it. It's something that treatment exists for.
Yeah, I appreciate you saying that also. That really was the catalyst for this conversation today, is again, helping people think about things that might not necessarily be a negative in terms of quality of life, or something that they feel they can put off, or that's just the way that my system is aging and that's just the way it is. I think you and I both agreed that there's no reason for patients not to seek help, see if there is an issue, ultimately take all the preventive measures that you've laid out for us today, check vitamin D levels, make sure that we're doing vestibular type exercises, keeping our balance system, our musculature in check, making sure our blood pressure, blood sugars, cholesterol is in check, so we have a healthy inner ear, making sure our vision is checked as well, because all of these things are contributing to our balance system. And ultimately, if we feel like we have a problem, to not take it into our own hands, make sure we have a professional like you guys down in Florida, like us in New York, and any of the colleagues we have around the country, around the world for that matter, to make sure we're properly diagnosing the problem so they can treat it and then ultimately get back to a healthy, long life. So,
yeah, very, very well said. Yeah, absolutely. I agree.
So I have just we have a couple more minutes here because I know you have to jump off, and I'm sure you got a ton of patients left in your day. I wanted you to spend just a couple of minutes talking about AIB in particular. I kind of talked a little bit about it at the front end of the show, but maybe you could talk a little bit about AIB and what the mission is.
Yeah, so here at the Institute, we've been in business for 30 years now. We kind of have three different silos, if you will, of our mission. Number one, and always at the forefront, of course, is patient care. Speaking of BPPV and balance and all these different kind of things, we've treated over 50,000 or 15,000 cases of BPPV. So our patient care is always at the forefront of our thinking and again, helping people in that way. But being that we have such a huge presence clinically, it gives us access to a lot of data. So we're also on the forefront of publications on how to treat and manage patients that are suffering from balance dysfunction, dizziness, vertigo, and all these different kind of things. So that's our second silo, is really clinical research. What can we do to again, educate and put research out there to help people like yourself and me deal with these patients more efficaciously and more efficiently. Our third kind of silo, if you will, is education. We're also the largest educator of physical and occupational therapists and audiologists as well in vestibular medicine. So I know you mentioned about physical therapy earlier, but physical therapists are also a huge part of what we need to be doing with these patients, and a flawless, seamless relationship between diagnostics and audiology and physical therapy are going to ultimately yield the best outcomes for the patient. So we also are huge believers in the education, and the things that we're talking about today, we're also training physical therapists on as well. We've actually got a room full of about 40 of them just next door that are getting ready to be certified in vestibular and concussion rehab. And finally, the last kind of silo of things that we're doing here, really exciting stuff, is we help audiologists, diagnosticians, ENT physicians, and physical therapists to manage their patients. So there are different centers of specialty care, which I know you're very familiar with, but we help with everything from physician marketing to clinical training, to equipment training, to report writing, interpretation, all these different kind of things to really help get our message out there. And again, that is, you don't just have to learn to live with it. Dizziness is something that we can absolutely intervene with and help these people.
No doubt. So I just flashed up on the screen the website for the American Institute of Balance. I think I would be remiss if I didn't mention Dr. Richard Ganzen, our discussion, who's the founder, who is a PhD audiologist who happens to be a kind of wonderkind in vestibular work. He's known all over the world. So he's the one who originally put us together. So I appreciate him for that. So if anybody's down in the Tampa or in the southeast of the United States, American Institute of Balance is based in Tampa, Florida, but you guys have worldwide reach. You have patients coming in from all over the world to see you. You also are training audiologists from all over the world, which again leads to that whole conversation with research and kind of developing best practices and really helping people get to the end point faster and more efficaciously. So we appreciate all the work that you guys do down there. If you guys are in New York, that's our website. Although NYHD, New York Institute for Hearing and Balance, that leads to our website as well. So you can always find out more about our practice and what we do for dizzy patients here in New York. Ultimately, the most important thing, as Dr. Joe said, is to make sure you get professional help. So anything else you wanted to add to the end of that, Doctor?
Yeah, no, I appreciate you having us. I know you guys are world renowned up there, and you've got the Northern Hemisphere, and we'll continue holding it down here in Florida. But always a pleasure chatting with you, and I appreciate you having me on today.
It was a true pleasure. Always great to pick your brain. You've served as a massive resource for me as well as my entire team up here. And look forward to having you back on for other episodes as well, because there's a lot of topics in dizziness I'd love to cover with you.
Absolutely. I'd be very happy to speak on anything that I can.
Awesome. Well, we'll talk soon. Everybody, I hope you enjoyed this episode of NYHD Life, the first episode covering BPPV with Dr. Joe Sakumura from the American Institute of Balance. Joe, thanks again. We'll see you soon.
Thank you, Craig. And, good seeing you.
Yep. Guys, check in for future episodes with Dr. Joe as well. Take care.